Thank you. So we wanted to present to you the J.J. Zhang Memorial Lecture. Ms. Zhang was a beloved patient, wife, mother, sibling, friend of the GynOnc cancer program. And as she fought a difficult battle with cancer with courage and resilience, after her passing, her family wanted to recognize her. And we have implemented this memorial lectureship in her honor. Next slide, please. This year, I have the pleasure of introducing Dr. Catherine Fu as our J.J. Zhang Memorial Lecturer. And Dr. Fu is an associate professor who, after a decade, has rejoined our Division of Gynecologic Oncology here at UCSF. She was a resident at Stanford, did her fellowship at UCSF and Stanford together with us, and then completed her PhD at Stanford before going to Washington University in St. Louis. She is a nationally recognized and well-funded researcher in basic science. She's the director of basic science and translational science for our G1 Oncology Division, and also holds the John A. Kerner Chair in Gynecologic Oncology. She's going to be speaking us today on new therapies in uterine and ovarian cancer. Thank you, Catherine.
Great, thank you so much. Let me load my slide. And I just wanted to say thank you very much for this opportunity and really for everyone who's on this webinar and in terms of spending your mornings with us. I really hope to spend the next 30 minutes giving sort of a quick snapshot. I mean, the title of the lecture, although really exciting, can really be a whole day, a whole week's worth of discussions and information. So what I tried to do today was really distill it down to the main questions, particularly for patients and consumers in terms of, when we talk about novel therapies, how do we think about them? And so what makes a therapy novel? And so I try to think about it in terms of, is it a new class of drug? Is it a delivery system? Is it maybe a biomarker for better selection for this drug? Is that is that how we define novel therapies? And so throughout this 30 minutes, I really want to focus on those types of ways to approach this question. And of course, we always think about efficacy. How effective is this treatment? Is it really going to have any response for my cancer, my tumor? And what about the side effects? We really need to really think about nowadays, not just how is it going to maybe take away and improve the disease, but also what are the side effects that actually might continue to have and might not be reversible after the treatment? And then really thinking about prior treatments and other residual side effects. How can we actually utilize that information to then guide us for the next treatment? If it's something where someone is having, sort of residual fatigue, if we talk about another medication that might be novel, but actually we know really makes the fatigue even worse, let's talk about that with your provider and figure out whether or not this novel therapy may be really the right decision in your pathway and in the journey. And so today I'll focus on ovarian cancer and endometrial cancer. And one piece to highlight when we think about ovarian cancer, we say that term, but it's a very broad term. And so I'm trying to, during this talk, really highlight some of the biology and the novel therapies that are perhaps specific to high-grade serous or specific to low-grade serous. And some of the clinical trials actually that are here at UCSF to help guide these treatment options. And then when we talk about endometrial cancer.
So we wanted to present to you the J.J. Zhang Memorial Lecture. Ms. Zhang was a beloved patient, wife, mother, sibling, friend of the GynOnc cancer program. And as she fought a difficult battle with cancer with courage and resilience, after her passing, her family wanted to recognize her. And we have implemented this memorial lectureship in her honor. Next slide, please. This year, I have the pleasure of introducing Dr. Catherine Fu as our J.J. Zhang Memorial Lecturer. And Dr. Fu is an associate professor who, after a decade, has rejoined our Division of Gynecologic Oncology here at UCSF. She was a resident at Stanford, did her fellowship at UCSF and Stanford together with us, and then completed her PhD at Stanford before going to Washington University in St. Louis. She is a nationally recognized and well-funded researcher in basic science. She's the director of basic science and translational science for our GynOnc Oncology division, and also holds the John A. Kerner Chair in Gynecologic Oncology. She's going to be seeking us today on new therapies in uterine and ovarian cancer. Thank you, Catherine.
Great, thank you so much. Let me load my slide. And I just wanted to say thank you very much for this opportunity and really for everyone who's on this webinar and in terms of spending your mornings with us. I really hope to spend the next 30 minutes giving sort of a quick snapshot. I mean, the title of the lecture, although really exciting, can really be a whole day, a whole week's worth of discussions and information. So what I try to do today was really distill it down to the main questions, particularly for patients and consumers in terms of, when we talk about novel therapies, how do we think about them? And so what makes a therapy novel? And so I try to think about it in terms of, is it a new class of drug? Is it the delivery system? Is it maybe a biomarker for better selection for this drug? Is that is that how we define novel therapies? And so throughout this 30 minutes, I really want to focus on those types of ways to approach this question. And of course, we always think about efficacy. How effective is this treatment? Is it really going to have any response for my cancer, my tumor? And what about the side effects? We really need to really think about nowadays, not just how is it going to maybe take away and improve the disease, but also what are the side effects that actually might continue to have and might not be reversible after the treatment? And then really thinking about prior treatments and other residual side effects. How can we actually utilize that information to then guide us for the next treatment? If it's something where someone is having, sort of residual fatigue, if we talk about another medication that might be novel, but actually we know really makes the fatigue even worse, let's talk about that with your provider and figure out whether or not this novel therapy may be really the right decision in your pathway and in the journey. And so today I'll focus on ovarian cancer and endometrial cancer. And one piece to highlight when we think about ovarian cancer, we say that term, but it's a very broad term. And so I'm trying to, during this talk, really highlight some of the biology and the novel therapies that are perhaps specific to high-grade serous or specific to low-grade serous, and some of the clinical trials actually that are here at UCSF to help guide these treatment options. And then when we talk about endometrial cancer, that again is a very broad general term. And so whether or not the question is this trial for any endometrial cancer in terms of recurrent, or is it specific for particular kinds, such as uterine serous cancer? And I'll highlight some of that biology and data as well. So this is taken from a recent review, actually, from the American Society of Clinical Oncology, ASCO 2022. And this is on ovarian cancer. And it's the group's way of distilling, what in their minds are novel therapies. And I thought this is a really great place to start when really figuring out and trying to explain what are the novel therapies in ovarian cancer currently that we think about nationally and internationally. So ways to think about it is, are we targeting the tumor microenvironment? And what does that even mean? So the tumor microenvironment means, where does the tumor sit? What are its neighborhoods? We talk about the omentum, we talk about the peritoneum. That is, in a way, the tumor microenvironment. And so are there ways to actually attack this and focus on the microenvironment? And I'll share some data with you on that. And then what about improving drug delivery systems? Some of you may have heard about this antibody drug conjugate or nanoparticle directed systems. And so I'll also have a slide kind of highlighting what that actually means within ovarian cancer or GYN cancers as well too. And what about PARP inhibitors? I think many of us have heard about PARP inhibitors. And truly, when we think about PARP inhibitors, we talk about Is it really targeting those with BRCA mutations or homologous recombination deficiency, genomic instability? And I'll have a slide talking about that. But we also have seen that for those who've had PARP inhibitors, that there could be resistance, or maybe for some, they're actually resistant from the outset. So how can we actually improve this therapy that we know can actually be really amazing for others? And how can we actually make that and sort of change the biology so that many more can respond to PARP inhibitors if they're perhaps resistant, even for the beginning of the disease course, or maybe after having received PARP inhibitors. And then how do you enhance PARP inhibitor activity? Can we combine it with immunotherapy? Can combine it with anti-angiogenic like bevacizumab? There's some trials about this work right now. And so all four of these are ways that are, really research is ongoing. We have some research that have already happened with clinical trials, but then there's, so many research and scientists are actually working on these specific questions as well as others right now. So I'll really just take one slide each, or one to a few slides each to really sort of highlight and summarize this here. So let's start with PARP inhibitors. And PARP inhibitors, I think of most of the novel therapies have really changed our landscape. And I won't have time to go into all of how it changed everything, but in general, for those who have BRCA mutations, alterations in the tumor, in germline, we see that they can be effective, but they also can incur resistance. So how exactly do PARP inhibitors work? I think that would be a way to kind of set the foundation to then understand how resistance can occur. And so the figure on you're in the middle, I guess, right here, that hopefully you can see my pointer, shows how a normal cell that, let's say, has a BRCA1 or 2 gene and protein that's intact. So what happens is when a PARP inhibitor comes in, it sort of attacks the tumor or the normal cell or tumor cell, let's say, and it doesn't allow these single strand breaks to be repaired. And so then there becomes additional breaks, such as double strand DNA breaks. However, with the intact active BRCA1 or 2 protein, the cell can repair themselves. And so the cell survives. So this happens, let's say, in tumor cells, for example. However, if there's a tumor cell that has a BRCA1 or 2 mutation or deficiency, we call it, this single strand break that then, again, is not able to be repaired because of the PARP inhibitor, then becomes a double strand DNA break. And then because the BRCA1 or 2 protein is not there, not active, then this actually causes DNA damage and then cell death. And so this is the terms, we sometimes use these terms called synthetic lethality, where we're taking the biology of a tumor cell and we're actually using it against themselves and actually applying this new therapy to actually allow it to, lead to cell death. However, we know that tumor cells are, sometimes can alter themselves and become resistant. And so this figure here, when you talk about targeting PARP inhibitor resistance, you can see all the different ways that groups are working at how to actually target this PARP inhibitor resistance. These are all the different ways that the tumor cell can perhaps be altered, and just really highlighting that these are the different ways to approach this. And then thinking about enhancing PARP inhibitor activity with immunotherapy, when we think about the combination, we also think about, sort of the side effects and what actually can happen too. So this is something that, as a clinician and as a researcher, we're really mindful of together to make sure that when we're combining it, the biology makes sense, but also really being aware of like how it actually manifests in, someone who's actually taking the targeted therapies. And then this here, when I have this HRD and HR non-HRD, it really just helps to highlight the idea that although I'm talking about BRCA1 and 2 mutations, there's a whole family of DNA repair proteins that actually can be altered that can lead to what we call homologous recombination deficiency that may still actually be improved response to PARP inhibitors, and perhaps benefit from targeting PARP inhibitor resistance. So again, I can talk many hours on this, but I think just in terms of the timing to move on. So in terms of the drug delivery system, how can we perhaps improve upon that? So some of you may have heard about antibody drug conjugates, and what does this actually mean? So I have a picture from the review here that highlights, sort of this payload and the target. And so to really distill it down, what is antibody drug conjugate? It's a way to deliver a drug. And how does it do it? So the key is actually this, the target. What is the target to an antibody drug conjugate? And what does that mean? So the target, it happens to be, perhaps think about it like a signaling protein. So I like to think about cancer cells where they have a certain language and they actually have signals that they like to express and talk about to themselves that helps encourage other tumor cells to come and become active. And so what antibody drug conjugates can do is that they take this neural pathway, they target it, so they focus. So we know, for example, cancer cells highly express, here, for example, on the table, folate receptor alpha or tissue factor, NaPi2b or HER2. So this antibody drug conjugate actually uses that as a target. And then it has what we call a payload or a toxin. And that's what the payload is here, where it's an actual, almost like a chemotherapy that then can go into the tumor cell and then lead to cell death. And the antibody drug conjugate is, currently also thought about in terms of, what are the side effects? Some of them are like very specific and different than what we're used to with chemotherapy. Some are also similar. So these are all the thoughts behind, kind of developing novel therapies and how to understand if this may be, therapy that could be useful for you. And so as a context, though, the antibody drug conjugates are currently not FDA approved. So these are all under clinical trial. Some of the clinical trials have resulted. I don't have time to go into all the results, but in general, there are some that look very promising for our field and for the treatment for GYN cancers. So in terms of targeting the microenvironment, this was another piece here. And here we're going to highlight AXL GAS6 pathway. And one of the reasons I have to say is that I did work on this pathway back almost 10 years ago as a graduate student. And back in the day, we were really trying to understand what are these signals that the tumor cells can actually express. And one of them that we identified was AXL. And, when we think about, okay, well, a tumor cell expresses a signal, then what? Well, we want to understand, does it really affect survival? If tumors have high expressing AXL, what does that mean for survival? And we did identify that high AXL did correlate with poor survival, you can see here. So this is a typical, what we call Kaplan-Meier curve. When we look at and compare tumors that have low AXL staining versus high AXL staining, and then we ask, what does it do to the progression-free survival or the overall survival? And so you can see that in women that have advanced stage ovarian cancer, for those that have low AXL staining, they actually have much longer overall survival than those have high AXL staining. So that made us think, well, what if we can target AXL? What if we can actually inhibit it? What does it do to the tumor cell? Would that actually cause the tumor cells to perhaps not be able to grow anymore? And we found that indeed that was the case. So when we actually look at these, and this is just a snapshot of the data, 2 different ovarian cancer cell lines, one grown from the ascites of a woman who signed consent to allow us to grow her tumor cells. And we actually treated these tumor cells in a dish and looked at treating with paclitaxel, a very common chemotherapy, versus the AXL inhibitor versus the combination. And you can see that each of these dark dots here represents a tumor cell colony. When we actually do the combination of the two, you can see these cell colonies are pretty much non-existent. And we are able to see this in at least 2 different ovarian cancer cell lines. And then this has led to a clinical trial, which I'll show you in the next slides. But I also wanted to highlight during this time too, an emerging data that we actually have recently published, and hopefully we'll be able to move to a clinical trial, hopefully someday, is the idea of a PARP inhibitor, olaparib, for example. So the same concept, we take ovarian cancer cells, place them on a dish, and treat them with a PARP inhibitor or the AXL inhibitor or the combination. And you can see the same thing, that when you look at the combination, there's definitely less tumor cells growing than when you actually treat with olaparib alone or AXL inhibitor alone, suggesting that perhaps this combination as well can maybe improve the sensitivity to PARP inhibitor. But I'll go back to the AXL inhibitor and the paclitaxel as well, because this is what has really developed into clinical trials. And so this led to a phase 1b clinical trial. So the phase 1 trials, what that really highlights is we're looking at safety and toxicity. And as a secondary outcome, we can look at efficacy, but truly these phase 1s are small studies that are looking at how safe is it and what are the side effects, and are any patients not able to tolerate this treatment combination. And so this was in a platinum-resistant setting. And providers and patients are able to decide if they wanted to have paclitaxel in combination with AXL inhibitor or pegloyliposomal doxorubicin. And then again, the safety was the main focus. And so in general, patients tolerated this very well. The main side effects were those that we would see with paclitaxel or pegloyliposomal doxorubicin. And this resulted in a publication that you see here. And so part of the secondary objectives, we always want to know, okay, we know it's safe, but is it effective? And so to do that, we look at parameters called complete response, partial response, or objective response rate. And this is based on the CT scans that we have during the clinical trials. And so we can see that with the combination paclitaxel, there were actually 2 women who had a complete response. And then there were 5 that had partial response, and we add together, the objective response rate was about 36.8%, which in terms of platinum-resistant ovarian cancer is one that is hopeful. And when we look at actually drilling down and saying, well, we know that some women receive bevacizumab, how does that affect maybe the response rate? And so this is very exploratory, and exploratory meaning that, this is not definitive, and this is just something we're trying to kind of understand if we can maybe improve responses based on, looking at different criteria. So very exploratory. So when we look at women who have no prior bevacizumab, and we look at this versus women who've had prior bevacizumab, we can see a pretty dramatic difference in response rate. So for women who have not had bevacizumab, the objective response rate was about 66.7% compared to 10%. And then this has led to the question of, well, can we in the phase 3 trial, when we're comparing standard of care to this combination, can we maybe actually focus on a cohort or a group of women who haven't had prior bevacizumab and see if indeed this is true? If truly maybe this can actually enhance the response of this combination. And we also looked at other markers that might actually be able to correlate with response. So one of the pieces I mentioned early on with novel therapies is, is the novelty of the therapy that there's a biomarker or something that can actually help predict or associate that there's going to be a response. Because right now it's been difficult for us to say, gosh, I can tell you, with 100%, certainty that you'll respond to this treatment. It's really difficult for us to do that. And so we're part of the research and part of the clinical trials, and the novelty is to say, can we do this actually? Can we figure this out? And so this was actually an attempt to do just that. So the blood of the women were taken during the clinical trial before one of the cycles. And then the blood was taken and actually analyzed for what we call soluble AXL and Gas6. So these are some of the molecules that are floating in the blood. And we identified that actually if there's a certain ratio of 0.773, the women were actually all responders if they had that ratio during that certain period of time. And so this is also going to be pursued for the phase 3 trial too, in terms of women having their blood drawn and measuring this ratio to perhaps hopefully confirm that this is indeed a way to optimize if we can figure out who would respond to this treatment. And so this has led to the phase 3 clinical trial that's actually open at UCSF and other places and institutions internationally, as well as nationally. And currently the cohort is really looking at the bevacizumab naive. So the ones that have had bevacizumab, that cohort has already been enrolled. And so we're really just focusing on the bevacizumab naive. There's about 60 more patients that are needed for the trial to really be able to then start answering the questions and trying to see whether or not this could be another treatment option. So with that, I'm going to now switch over to low-grade serous ovarian cancer. And I hope in the high-grade serous ovarian cancer segment, we were able to really understand what novel therapies are in terms of delivery system, in terms of new different pathways, in terms of how to maybe think about improving resistance and how to actually go from the laboratory research findings to a phase 3 trial. So now what about low-grade serous ovarian cancer? I don't really have time to kind of talk about all the nuances about this, but hopefully in the other sessions we can address it. But in general, we think about this type, we want to use the biology. So we know that low-grade serous ovarian cancer is different than high-grade serous in terms of its biology. And how can we utilize this biology to create and develop novel therapies? Currently back when I was training low-grade serous ovarian cancer, we gave chemotherapy. And, although that is still an option, we want to really start thinking about other ways to treat it based again by the biology. So one way to address this is to look and see, well, what else do these low-grade serous cancers express? This whole signal, like what kind of language are they speaking? And so we see that actually low-grade serous cancers also have expressed and have CDK4. This is a checkpoint part of the pathway. But I think the big picture piece is that CDK4 has been shown to drive resistance to endocrine therapy. And what does endocrine therapy mean? It means endocrine is an inhibitor to the estrogen and progesterone pathway. And so thinking about it this way, the question is, can one of the novel therapies be, can we inhibit CDK4/6, and that would actually enhance the response to endocrine therapy? And interestingly, this concept has been thought about from breast cancer. And so this is a paper that was recently published in March 2022 that asked this question of advanced stage breast cancer. And this is what it's typical, again, Kaplan-Meier curve. And in this case, both groups had letrozole, which is in endocrine therapy. And what they asked was for women who actually had ribociclib, which is a CDK4/6 inhibitor, with letrozole, do they actually do better in terms of survival? And indeed, you do find that they do. So there is 63.9 months for ribociclib with letrozole compared to placebo with letrozole alone. And this has led to the development of GOG 3026, which is a phase 2. So phase 2s are for efficacy because it's already passed the phase 1, which we know is for safety. So for the phase 2, it's looking for women who have recurrent low-grade serous ovarian cancer and the opportunity then to receive letrozole and ribociclib together. And that starts to highlight this trial is open at UCSF for enrollment as well. And so this really gives an opportunity for novel therapies, novel ways to use the biology of the tumor almost against itself, how can we actually better target these tumor cells using the biology? So next, we're going to go to endometrial cancer. And this slide highlights that endometrial cancer can be molecularly thought of in terms of pathology, like under the microscope, as well as sequencing. And it's a complicated slide, and it's really just to kind of highlight that we're trying to think again about the biology of the tumor and how to utilize this for treatment options, such as chemotherapy and radiation, or perhaps more observation and close surveillance. And this slide looks at sort of the other novel therapies, what are the signals that these endometrial cancer cells express? And so here I've highlighted, it's a very busy slide, which actually is encouraging me that we're really trying to really understand endometrial cancers and how to actually develop personalized ways to address this. So in the purple here are highlighted new therapies. And these new therapies are actually in a clinical trial that I'll show in the next slide that's open at UCSF. And this really highlights the way that we're targeting endometrial cancer at the different ways and different parts of its disease progression. And so here is AFT50 Endomap, and these here, you can see these are the study drugs here. And this is one that's actually designed for biomarkers as well as novel therapies. So really suggesting that for tumors that are biomarker negative, they would then receive an anti-androgenic plus immunotherapy. For those that have a PI3 kinase AKT signature, then they receive an AKT inhibitor with immunotherapy. And those have a genomic loss of heterozygosity, receive a PARP inhibitor plus immunotherapy. And so this is a trial, again, that is open at UCSF. And the last few slides, I really wanted to kind of highlight what are the novel ideas, because these are really, not standard of care right now, but just how we're thinking about the field. So one way is I mentioned, how can we predict who can respond? So this is a trial that we opened up at Washington University, in which we asked the question for those who received immunotherapy and endometrial cancer, can we predict who would respond better? And so we're able to collect blood before and after pembrolizumab, and they performed a CyTOF, the single cell analysis of the immune cells, and to ask, are there patients that actually have different immune cells when they actually respond versus don't respond? And so here you can see just one quick slide that for patient 5, who was a non-responder, they actually had different trajectories of their immune cells. So for those who responded 6, 8, and 10, you can see these immune cells actually went up after the immunotherapy, and they actually were responders, highlighting, suggesting that maybe we can start to predict, who would respond to this immunotherapy earlier on, rather than, sort of giving immunotherapy and hoping that it actually will be a response. And then lastly, we'll talk about one slide, cell engineering, and what does this all mean? So there's in other fields such as leukemia and lymphoma, you can see down to your right, the FDA-approved CAR T-cell therapies. And ovarian, endometrial, cervix, this has been ongoing. And really the question is, how can we use and utilize the immune cells from our own bodies to be able to attack and fight the cancer? And one way I want to highlight is the CAR protein. So one thing that we are actively doing here is really trying to identify what are the actual proteins that are specific to GYN cancer, specific to ovarian and endometrial cancers and cervix cancers, and then utilize the development of this to be able to then benefit our patients. And so this is a schematic of, sort of the whole process of it. And UCSF has been, committed to this in terms of the Living Therapeutics Initiative that's here at Mission Bay. And so this is more just a, hopefully in the next few years when we have this symposium, we can, certainly share some more updated results on that. So just wanted to end to acknowledge, of course, the people in the lab that actually did the work and performed the work. Special thank you to Maggie Mullen, who is currently at WashU and had worked on the AXL and the Elaborate project and currently has a lab there. And then, of course, my clinical colleagues and Stephanie Cham and I are the newbies. So we still need to have our pictures here too, but just wanted to highlight that. And thank you again for your time.
Thank you so much, Dr. Fu. We have time for one question that was put into the chat earlier. And I think that you talked about it a little bit, but for the audience specifically, why are PARP inhibitors not recommended for endometrial cancer? Because we're talking about all these different targets, and PARP inhibitors sound great. Why not for endometrial?
Yes, so I would say that stay tuned, because that is definitely a way that we are actually thinking about and looking at endometrial cancer. And part of it is actually more let's say biomarker driven. So for those that have a BRCA 1 or 2 alteration, that could be a possibility. It's just not as common in endometrial cancer. That's one of the main reasons. And then really we're then thinking about it broadly, like not just the BRCA genes, but what about the homologous recombination repair family? And so that's the one I mentioned before about thinking about homologous recombination deficiency, and maybe that those tumors would be more accessible to PARP inhibitors. So I would say that's actually where the field is going.
Great. We'll continue to watch the space. Thank you very much, Dr. Fu.
Thank you.